Oh, hi, this is Dr. Paul Sachs, and welcome to this next quarterly brief. We've just gone through the second quarter of 2023, and joining me today is Dr. Mary McKellar from Duke University School of Medicine, where she is an associate professor in their Division of Infectious Diseases. Welcome, Mary.
Hello. Thanks, Paul. Good to be here.
Great. So as we often do, I'm going to start us off with a little bit of epidemiology. There was the new HIV surveillance report released in May, and what it showed is that there was an increase last year in the number of new cases of HIV diagnosed from 30,000 to 36,000, which is an 18% increase and would be very alarming if it had not been for the artificial decline the previous year because of COVID. Men still account for the vast majority of cases, 79%. Women were 18%, and trans women 2%. And again, we saw that the dominant mode of transmission was men who have sex with men, at 67%, with 22% accounted for by heterosexual contact, and injection drug use, 7%. One of the things that's been notable in the epidemic in the United States from really the get-go was that people of color are at greater risk of getting HIV. 40% of new cases are in Blacks or African Americans, and they're approximately 12% of the population, 29% in Hispanic Latinos, and 25% in whites. Anyway, that was the report. I should say that the South is still the region of the country accounting for the largest number of cases. So 52% in the South, much smaller numbers in all the other regions. Okay, on to art studies. Take it away. Tell us about Atlas 2M.
Yeah, so this is an article that was just published in CID in May, and it presented the 152-week, which is about 3-year data from Atlas 2M, which, as you recall, evaluates the effectiveness of long-acting cabotegravir with rilpivirine administered every 8 weeks, hence the 2M, versus every 4 weeks in persons with suppressed HIV. And so the endpoints there were a proportion of patients with less than 50 copies per mil or patients who are 50 and above, as well as incidence of confirmed virological failure and safety and tolerability. And the bottom line was that cabotegravir plus rilpivirine demonstrated non-inferior efficacy at 8 weeks compared to 4 weeks, 3 years out, with 87% who had a viral load of less than 50 in the 8-week arm and 86% in the 4-week arm. And both dosing regimens, as you would suspect, were safe and well tolerated. When you look at persons who were greater than 50 copies, though, the percentage was slightly higher in the 8-week regimen, so about 2.7%, which is 14 people, compared to the 4-week regimen, which is at 1%, about 5 people. However, the adjusted treatment difference ended up being 1.7%, which met that 4% non-inferiority threshold. And I do recommend people take a look at the accompanying editorial, which talks about this discrepancy. So I know you're going to talk about this further, but this does bring us some pause as we have to figure out who the best candidate is for these long-acting injectables and for 8 weeks, which is certainly what all of our patients and clinics want.
Well, it very much relates to the paper that I was planning to discuss next, which incorporates some of the data from Atlas 2M. And this is the updated multivariable analysis looking at predictors of virologic failure in these pivotal studies of rilpivirine. And this is really, as noted, an update of a previously published study from a couple of years ago. And it's actually very hard to follow the precise methodology in papers like this for non-statisticians like you and me. But what you ultimately come to is a multivariable model where you look at what the independent risk factors are. And so the independent risk factors were baseline rilpivirine resistance to mutations, subtype A1A6, and BMI greater than 30. And what you mentioned, which was the every week versus every 4-week strategy, was a borderline significance, but didn't make it in the final models. A few comments about these. One, rilpivirine RAMS is, I think this is probably the best example of use of archived genotype that we have out there, because none of the people in these studies could get in if they had rilpivirine RAMS, known rilpivirine RAMS, from any historical genotype or virologic failure. So that one is, here we have the use of the test that is so incredibly controversial this is the test applied to this clinical trial, and it's really quite useful. The next is subtype A1A6. Most genotypes at baseline will give you the viral subtype, but often it's something that's not noted in the chart. I guess it's something we may have to go digging for. Fortunately, that subtype isn't very common in the United States. It's most common in Central Europe and Eastern Europe. And then BMI greater than 30. Well, there's, of course, an obesity epidemic in this country, and there are a lot of people with a BMI greater than 30. Do you use a longer needle? Most people suggest you do. Do you not avoid this entirely in this population? I don't know. I don't think so. But the bottom line is, as your paper and my paper show, is that there is a small but detectable risk of treatment failure with resistance with cabrolpivirine, and we do not see that with oral ART. And at least from my perspective, this has to be part of the patient education before someone goes on this treatment. So tell us about the next study relevant to injectable cabrolpivirine.
Yeah, so the next study was an at-home survey to examine characteristics of people with HIV who prefer to remain on daily oral therapy or rather than switching. And so in this study, they use a discrete choice experiment to examine characteristics of those who will choose the daily oral therapy versus a hypothetical long-acting antiretroviral option. And so they actually looked at 4 different treatment types: long-acting oral pills, injections under the skin, injections into muscle, and implants. Those were the 4 hypothetical choices. And each choice task offered 3 options, either 2 of these hypothetical options versus their current oral therapy. And in summary, 11% chose their current daily treatment over long-acting ART in all choice tasks. And the characteristics of those who wanted to stay on their oral regimens included lower education, good adherence, more aversion to injections, which seems very obvious. And then in this study, living in Atlanta, actually. So they were all more likely to prefer staying on their current oral therapy. Viral suppression was not predictive of preference.
I'm going to leave the world of long-acting injectable antiretrovirals and go to an older world, which is the world of HIV neurocognitive impairment. This is a really impressive and I have to say, very ambitious study. It's a phase 4 double-blind placebo-controlled trial of ART intensification for people with neurocognitive impairment. And so this took a look at several hundred people with this problem and then randomized them to continue their current ART or to add active treatments to it. So they would continue their current ART and add 2 placebos, or they would continue their current ART and add dolutegravir and Maraviroc placebo, or they would continue their current ART and add both dolutegravir and Maraviroc actively. So the bottom line for the primary endpoint was that it didn't really improve anything. But I do want to underscore an important secondary endpoint. And what they showed in this study is that the people who added active dolutegravir to their background ART regimen did not experience weight gain. So a negative study, but I thought a very good one, and certainly deserves to be mentioned. All right, I'm going to shift gears now. We're going to talk about something that was observed in an interesting laboratory-based study. It was a retrospective cross-sectional study of false positive rates with 4th-generation HIV antibody tests in people with COVID. And this was stemmed from an observation that they made that they thought that people who were getting HIV tests who had simultaneous COVID had more false positive results on their 4th-generation assays. And you know, I have to say, when I first heard about this study, it kind of resonated with me a little bit. It seemed to me that we were getting a lot of HIV reactive screens, 4th-generation screens, that were later not confirmed during the height of the COVID period. And I wasn't sure whether that was just an observation that was a false one or whether it was his bias, ascertainment bias. We were testing so many people. And they were in the hospital a lot. And anyway, turns out that they did observe that people with COVID were more likely to have a false positive reactive screen. I don't know if we still would now. COVID disease in 2023 is not the same as it was in 2020. as you can recall, that back then it was this hyperinflammatory syndrome with immune activation, and right now it's much more like a standard respiratory tract infection. So, what do you do? You think we would still observe this if we redid this study today?
No, I agree with you, and it would be an interesting thing to look for, but I don't think so. I mean,
Yeah,
I wasn't entirely surprised to learn that they were getting these false positives because we have seen it with other inflammatory related states, like pregnancy, and I've seen it with even dengue fever we had once the other
yeah,
not too long ago. So I wasn't surprised to see this at
yeah.
all.
All right, what's next up for you, Mary?
Yeah, so the next article was an open label randomized controlled non-inferiority study comparing low dose amoxicillin monotherapy with combination of amoxicillin and probenecid. But this article comes from Japan, where the STI guidelines have actually recommended low dose amoxicillin, which is 1,500 milligrams a day, for early or late syphilis since 2002. And I was not aware of this at all. And so here they randomized patients 1-to-1 with amoxicillin 1,000 milligrams plus probenecid 250 milligrams thrice daily. I like to use that word, versus amoxicillin monotherapy 500 milligrams thrice daily. And the duration was 14 days for early and 28 days for late. And the primary outcome was cumulative serological cure rate within 12 months, which was a fourfold decrease or a negative conversion in the RPR. The study basically revealed that low dose amoxicillin achieved 90.6%, and the combo regimen achieved 94.4% serological cure within 12 months. And that's using the conventional manual RPR. And these rates were actually even higher for early syphilis. And so, per the authors, both regimens were actually comparable in terms of efficacy to intramuscular benzathine pen-G, although there was no direct comparison in this
Hmm.
study. That being said, though, the low dose regimen did not show non-inferiority of cure compared to the combo regimen for overall syphilis, for early or late syphilis between the two groups. The difference in the serological cure rates was quite small, however, and the authors think that the sample size might be partially to blame. So I think that further studies are definitely needed before this is ready for prime time, especially with a comparison to IM Pen-G.
I think that we really should take a look at some of our syphilis treatment dogmas and analyze them and say, is this really the way we have to do it? I mean, there's not a whole lot that we treat with benzathine penicillin. I understand the theoretical rationale behind it. The organism is exquisitely sensitive to penicillin. You don't need high doses. It replicates very slowly, and therefore you need sustained levels. But it is a kind of a pain, both literally and figuratively, with these injections. At least our standard is to give 2 injections for each 2.4 million unit dose. And now that there's a shortage, I wish we had a really well-studied oral option. And I think the experience in countries like Japan, which don't have benzathine penicillin, are really going to be useful. Switching now to a different complication, which is hypertension. I wanted to bring up the NEAT 022 trial. The NEAT 022 trial was a randomized clinical trial done in Europe of people at high risk for cardiovascular disease on boosted protease inhibitor-based regimens, randomizing them to switch to a dolutegravir-based regimen or to stay on their boosted PI. Now, the various waves of this study, results of various waves of the study have come to us over the years. The first was that the lipids improved. And viral suppression was maintained. The second part was more of a surprise. It turns out that people who switched off the boosted PIs actually gained weight. So now we come the third one, and that is an analysis of hypertension. And the reason why this is important is because there have been some observations, some from clinical trials and some from anecdotes, that dolutegravir and other integrase-based regimens are associated with a higher incidence of high blood pressure. And what the NEAT study showed in this latest published paper is that, in fact, there was no major difference in the incidence of hypertension, at least not, I think, one that is clinically relevant. Now, granted, these are older people who have, lots of risk factors for cardiovascular data already. And in addition, it is possible that in people who gain weight, significant amounts of weight, their blood pressure is going to go up. But does dolutegravir itself, is the medicine itself causing high blood pressure? And I don't think the data are there yet. I think this is something that we actually should keep an eye on. And it's part of the routine evaluation and management of our people with HIV when they come in and see us, is checking their blood pressure. But I don't see this as a toxicity signal quite yet in the clinical data that we have. What has been your observation, Mary?
I mean, hypertension's tough, and
Yeah.
everyone's got it, is what I think. I'm here in my office surrounded by boxes because I'm often providing swag at events and whatnot. And the most important thing I have is this box of blood pressure cuffs. That's probably the best thing that we've been providing to our patients as of recent. We got a grant to hand out blood pressure cuffs. I feel like I'm talking about blood pressure all day long.
Well, it's incredible, as you mentioned, it's incredibly common, and it would be important to know if we had one of these, one of the most commonly used drugs or drug classes ended up being causative of high blood pressure. All right, now we're going to shift topics to women in HIV.
Yeah, so the next article was called the VESTED study, which stands for Virologic Efficacy and Safety of ART Combinations with tenofovir alafenamide, tenofovir disoproxil fumarate, efavirenz, and dolutegravir. So this is a large ongoing efficacy and safety study that's taking place in 9 countries. It's part of the overall IMPACT clinical trials program, in which ART naive participants who were pregnant were randomly assigned 1 to 1 to 1 to one of 3 oral regimens. And they were started during pregnancy. Up to 14 days of prior or antepartum ART was permitted. So in this paper, they're looking at 50 weeks postpartum, and what they saw was similar high efficacy in the combined dolutegravir containing groups and the efavirenz containing group. However, in the efavirenz group, women were more likely to stop or switch due to virological failure or resistance. And again, remember, this is a safety study. So the proportion of adverse events of grade 3 or higher for both the mother and the woman at 50 weeks postpartum was actually similar among all the groups. However, and I don't want to cause too much alarm here, what was striking was that there was a higher proportion of infants who died in the efavirenz containing arm, 7%. Compared to 1%. And it typically occurred in the 4 weeks of birth. The authors kind of speculate that it has something to do with higher rates of preterm birth and small for gestational age in the infants in the efavirenz group compared to the combined dolutegravir group, or lower weight gain in the women on efavirenz. But it obviously needs some more investigations. And of note, no infants were born with neural tube defect, the famous neural tube defect, but again, no one started during their first trimester.
To me, this study, and I have to, disclosure, I'm on the study team. This study really transforms our understanding of the safety of dolutegravir in pregnancy, and then also the safety of tenofovir alafenamide in pregnancy. So right now, at least in our center, the preferred regimen is tenofovir alafenamide, emtricitabine plus dolutegravir, TAF50C plus dolutegravir, 2 pills. And by extension, if people are receiving bictegravir FTC TAF and they get pregnant, we're not generally switching them. Okay, we are now going to talk more about pregnant women with HIV and discuss the controversial issue of breastfeeding, because obviously globally, many women with HIV who have babies do continue to breastfeed, even though obviously there is a small risk of HIV transmission. Now that risk can be dramatically reduced by suppressive ART. And so the question remains is, should there still be this recommendation to formula feed, if possible, after delivery? Well, some women choose not to. And so in this study, which is called Breastfeeding Among People with HIV in North America, a multi-site study, women in North America were surveyed, 8 sites in the United States, 3 in Canada, and asked about breastfeeding in pregnancy. 72 people chose to breastfeed. And they basically, the reasons they gave for doing it was that they had health benefits of breastfeeding, which are well known, community expectations, which in some cultures very much so, and then the third, which is parent-child bonding, and they didn't see any, didn't observe any transmissions. And I feel like this study, even though it's a relatively small study, it still is the largest survey of its kind of women who breastfeed in North America after delivery, women with HIV breastfeed. So, and it really leads us to the discussion of the perinatal guidelines, which now say that really this is a decision to be made, with involving patient preferences, and have a discussion with your patient about the benefits of breastfeeding, have a discussion about the potential risks, emphasize the low but non-zero risk of transmission, and then if women decide to breastfeed their infant, no longer do we need to do anything punitive like get social services involved. And I was really glad that the perinatal guidelines have made that change, and a study like this one can support that. Next study, Mary?
Yeah, so the next study was a retrospective study on primary anal cancer screening in women at Mount Sinai in New York City. So this was a very interesting article for me as we are trying to build up our own anal dysplasia program here at Duke. And this is following the results from the ANCHOR study, which showed that treating anal high-grade squamous intraepithelial lesions will prevent anal cancer in persons with HIV. So the authors, start by reminding us that the incidence of HPV-associated anal cancer is significantly elevated in women with HIV compared with the general population. And I have to say, I want to put a shout out to the HIV clinic at Mount Sinai. It sounds like they've been routinely conducting anal PAPs and high-risk HPV testing in all their female patients at time of cervical cancer screening. And I think that's just great. They've
been leaders in this for a while.
Yeah, it's impressive. So here they present the results of primary anal cancer screening in 381 women with HIV, of whom 68% had ascus, LSIL, or HSIL on their anal PAP, versus 28% with genital cytological abnormalities. High-risk HPV in anal screening was found in 61%, and HPV 16 was found in 13%. And these are higher than what they found in the genital samples, which were 30% and 4% respectively. So one of the parts of the study I think that was really interesting is their discussion about whether genital samples could be used as a predictor for anal screening. And they did find that genital high-risk HPV and HPV 16 predicted anal high-risk HPV and HPV 16 respectively. And they also found that genital high-risk HPV and HPV 16 predicted histological anal HSIL. However, they emphasized over and over that anal HPV disease was more prevalent than genital HPV. And additionally, the majority of the women who had histological proven anal HSIL occurred in women who were HPV negative or cytologically negative, normal on their cervical screening. So this just basically suggests that routine cervical screening will not offer any kind of clinical utility here as we try to stratify who is appropriate for or who should be reviewed for anal HSIL risk.
Yeah, I mean, it's fascinating to start exploring this population for screening, because we haven't typically thought about screening women as much. I do have this one caveat, which is that there is yet to be a study of anal pap smear screening. All of these studies are more downstream procedures. They're high resolution anoscopy. What should we do before that? And I think that is what we really don't know. Let me totally shift gears now and take us into the world of very, very briefly and in a very big 10,000 feet view way into the cure space, and tell you about some humanized mice. Imagine you have some humanized mice who have HIV and they get virologically suppressed. So far, so good. And then you go and take the latest in gene editing technology and you use CRISPR to eliminate CCR5 and long terminal repeat GAG. And you treat them with this combination of antiretroviral therapy and these two CRISPR approaches. What happens to these humanized mice and their HIV? Well, very excitingly, there was 58% of them had elimination of replication competent virus. And they looked in the lymphoid, bone marrow, central nervous systems. They didn't find anything. So this is amazing. And it's the kind of technology that maybe one day we'll be able to apply to our patients. I'm more optimistic about this than I am about those latency reactivation strategies where you basically turn on the virus and then zap it with some immune activating thing. I don't think that that's ever going to really be safe.
Our final paper is actually looking at cannabis. Why not end with? So 23 states actually now have measures that allow for non-medical use of marijuana. Not North Carolina, though. And I suspect many HIV providers now are having patients come in and speaking on the benefits of cannabis on their physical and mental health, including some of our older patients, which is the vast majority of my clinic. So anyway, this article describes a longitudinal 10-year study in California, of course, examining the relationship between cannabis use and cognitive and functional decline in persons who were aged, I think, 50 and up. And they follow persons through self-report on their cannabis use. And then they had cognitive and functional outcomes, which they measured using some standardized assessments. And they classified cannabis by frequent, which is greater than weekly, occasional, which is once a week or less, and then non-cannabis users. And so what do you know? The results actually show that cannabis use was not associated with significant declines in cognitive functioning or everyday functioning in older adults. In fact, Paul, occasional cannabis use showed better global cognitive performance overall compared to non-cannabis users. And the rates of cognitive decline and functional problems really didn't vary by how much cannabis was used, aka frequent cannabis use didn't really relate to worse outcomes. On the other hand, interestingly, patients with recent cannabis, aka those who had THC still in their urine, had short-term decrease in their global cognitive performance at the time of the study, which was really driven by memory issues. So while this is promising, more data is certainly needed on the benefits of cannabis products. And we can't really say whether it's going to help prevent dementia just yet. But this paper is out there, and so I'm sure we'll hear more from others soon.
Yeah, I mean, it's a drug studying this drug has been so difficult because of the legal entanglements. There are studies of alcohol in therapies because alcohol is, approved, whereas the federal government, I don't think, has funded any research on cannabis, as far as I know, whereas it's really crying out for a good study. I think I can think of several I would do. I would do a study in people with chronic pain. I would do a study of people with chronic anxiety. I would do a very careful, placebo-controlled trial and see what it's really doing. Because one thing I guarantee, it's not doing as much as the advocates say it is. And it's not doing as little as the opponents say it is. It's doing something. Yeah. We just have to figure out what that is. Well, I got to say, Mary, this was very enjoyable. Thank you for joining me on this quarterly brief. I hope we'll get a chance to do it again soon. And thanks to all of you for listening.
Thank you very much.